welcome to the deep dive. You've brought us, well, quite a stack of incredibly helpful revision notes focused on a specific skin condition, Bowen's disease.
That's right.
Also known, I see here, by a more technical name, squamous cell carcinoma in situ. So our mission today is to really go beyond just reading these notes. We're going to unpack them, pull out the absolute highest yield stuff, connect the dots, and turn it into something clear, memorable, perfect for getting a solid handle on this condition quickly, especially if you're revising.
Exactly. Think of us as, well, guides through this material. We'll highlight the crucial facts, explain what they actually mean, and make sure you walk away with a really firm grasp of what Bowen's disease is, why it pops up, what it looks like, and critically, how it's managed and, what the outcome generally is. We'll stick strictly to the material provided.
Okay, let's unpack this then. Let's start right at the beginning. What exactly is Bowen's disease sort of at its core?
So the core definition is really key. Bowen's disease is fundamentally a precancerous skin condition. And that other name you mentioned, squamous cell carcinoma in situ, well, that tells you pretty much exactly what it is. It's the very earliest form of squamous cell carcinoma.
Right. And that phrase in situ, what does that really mean here? Why is that specific term so important?
That's the defining feature, really. In situ basically means in its original place. So it signifies that the abnormal growth of those squamous cells is entirely confined to the epidermis.
The epidermis, that's the outer layer of the skin.
Exactly, the very top layer. And crucially, it has not invaded any deeper tissues beneath that layer. That's the key point.
Got it. So it's like rogue cells, but they're still trapped right there on the surface. How does this, surface level issue typically show up? What would you actually see on someone?
Clinically, it usually presents as a scaly patch or maybe a plaque. It's often described as pruritic.
Meaning itchy.
Itchy, exactly. And erythematous, which just means it looks red or inflamed, and it can appear pretty much anywhere on the body, which is, a bit unsettling, but some places are definitely more common than others.
Okay. Does it grow fast? Or
No, that's another key thing tied to that in situ nature. It's generally slow growing. The risk of it actually progressing to invasive squamous cell carcinoma, where it breaks through that lower barrier and goes deeper, that risk is relatively low, thankfully, even if untreated. The notes suggest maybe about 5% overall, perhaps closer to 3% for typical cases.
So that slow growth and the fact it stays in situ, those are the main things separating it from invasive SCC, which is, obviously a much more serious diagnosis.
Precisely.
Yeah.
That intact basement membrane, the layer keeping it confined to the epidermis, that's the critical difference. In invasive SCC, that boundary has been breached. Here, it hasn't.
And the overall outlook then, once it's actually identified?
The prognosis is excellent, really excellent, especially once it's properly treated.
Okay, that's reassuring. So we know what it is, it's manageable. But why does it happen in the first place? What are the underlying causes, the etiology, and the risk factors that make someone more likely to get Bowen's disease?
Right, the causes. Well, the biggest culprit, the number one driver by far, is ultraviolet radiation exposure. UV light.
From the sun, presumably.
Yes, sun exposure is huge. Also, using sunbeds or even having had radiotherapy in the past, this is a really significant factor, particularly for people with fairer skin types who are just more susceptible to UV damage.
Makes sense that sun damage would be a major player in skin stuff like this. What else is on the list in the notes?
Other factors include things like chronic skin inflammation or maybe previous injury to the skin. Human papillomavirus, HPV infection, is also strongly linked.
HPV, really?
Yes, specifically HPV-16 is strongly associated. You might know that strain is linked with other cancers too.
Right. Okay, so HPV isn't just, a genital thing. It can affect the skin this way too.
Exactly, and HPV-16 is the one highlighted here. Another really significant risk factor is immunosuppression. So people whose immune systems aren't working at full strength.
Like transplant patients.
Exactly. Organ transplant recipients or people with conditions like AIDS, they're more vulnerable because their body is less effective at spotting and clearing out these abnormal cells before they become a problem.
And are there any chemical links mentioned?
Yes, certain carcinogens are implicated. Arsenic exposure is specifically mentioned as increasing the risk. And the material also notes it can rarely develop in pre-existing benign things like seborrheic warts. But the main drivers are definitely UV, HPV, and immunosuppression.
Okay, this is where it gets really interesting for me. How do those risk factors like UV light or HPV actually cause Bowen's disease at the cellular level? What's the pathophysiology happening under the skin?
Right, the mechanism. It basically starts with that initial insult, could be UV radiation, could be HPV, or another factor causing DNA damage inside the squamous cells of the epidermis.
So damage to the cell's actual genetic code.
Precisely. That DNA damage messes up the normal control mechanisms for cell growth, leading to what we call abnormal proliferation, basically, uncontrolled growth of these damaged squamous cells. But, and this is the crucial part that ties back to in situ, this abnormal growth is intraepidermal.
Meaning it stays stuck within the epidermis.
Exactly. The damage, the abnormal growth, it's all limited to that top layer.
Yeah.
The critical point, the barrier that defines it as in situ, is something called the basement membrane. It's a thin layer separating the epidermis from the deeper dermis below.
Okay.
In Bowen's disease, that basement membrane remains intact, unbroken. The abnormal cells are multiplying, yes, but they haven't broken through that boundary.
Okay, so the pathophysiology itself explains why it's labeled in situ. The problem starts and is contained right there in the epidermis because the DNA damage hasn't sort of given the cells the ability to invade deeper yet.
You've got it. It's a problem confined to that top layer because the cellular changes haven't progressed to the point where they can breach that critical barrier.
Right. Makes sense.
Okay, let's maybe zoom out a bit now and look at the bigger picture. Specifically, some numbers from the UK, from the epidemiology section of your notes.
The stats. Always good to know. How common are we actually talking here?
Well, the incidence in the UK is estimated at approximately 15 per 100,000 people per year. It's noted as being higher in sun-exposed areas, which, again, ties right back to the cause, the etiology.
And overall prevalence. Do we know how many people have it at any one time?
The overall prevalence isn't clearly defined, apparently, but it's generally considered relatively rare.
Okay. Is it seen more often in men or women?
Interestingly, the data suggests it's actually more common in women. They seem to account for somewhere between 70% and 85% of cases in the UK.
That is interesting. And what about age? Is it an older person's condition?
Yes, it typically affects an older demographic,
Yeah.
usually appearing between the ages of 60 and 70 years.
And you mentioned location earlier. There was something specific about the UK.
Yes, this is a notable point. While in some other countries, maybe like the US, it might be more frequently seen on very obviously sun-exposed areas like the head and neck, the notes specifically point out that in the UK, it's more commonly found on the lower limbs.
The lower legs. That's quite a difference. Any idea why? Maybe, I don't know, different clothing habits or sun exposure patterns over a lifetime?
It's possible, or perhaps differences in diagnostic practices or awareness. It's definitely an interesting geographical detail to keep in mind.
Okay, let's get back to what you actually see.
Mm.
If you encounter Bowen's disease, what does it look like clinically? Can you paint us a picture of its typical appearance?
All right, so the classic description is a well-demarcated patch or plaque. Well-demarcated, meaning it usually has fairly clear, though sometimes irregular borders separating it from the normal skin around it.
And the surface.
Typically scaly. And as we said, erythematoso, red.
And we mentioned it could be anywhere, but are there common sites besides the lower legs in the UK?
Yes, commonly found on sun-exposed areas too, like the face, the scalp, or the back of the hands. Head and neck are common in other places. And there's a specific important location to mention, the genital or perianal area. When Bowen's disease occurs there, it actually has a special name.
Oh, really? What's that called?
It's called erythroplasia of Queyrat.
Erythroplasia of Queyrat. Sounds quite specific. Is it just Bowen's in that particular spot?
Essentially, yes. It's Bowen's disease occurring on the glans penis or sometimes other mucosal or genital sites. Clinically, it tends to look a bit different down there, too often more velvety and red rather than thick and scaly.
Right. Does it usually cause symptoms, like the itching you mentioned?
It definitely can be asymptomatic. Someone might not notice it, or it's found incidentally. But often, yes, it causes itching or sometimes a burning sensation, that pruritus we talked about.
Okay. Any other characteristics we should look out for?
Well, it's slow growing, as we established. The borders can be quite irregular. You might see some crusting on the surface, or it could even bleed a bit, especially if it gets scratched or irritated.
And sometimes it can actually be pigmented, meaning it might have some brown or darker color within it, which can, make diagnosis a bit trickier, maybe make you think of other things.
Like melanoma?
Potentially, yes, that would be on the list. And usually it's a single lesion, just one patch. But some people can develop multiple lesions.
So despite that sort of classic description of a scaly red patch, the appearance can actually be quite varied then.
Absolutely. The material really emphasizes this. It can present as flesh-colored, quite dry, very scaly, heavily crusted, or even pigmented. So you can't always rely on spotting that typical scaly red look. You have to keep an open mind.
Okay.
Now, precisely because it can look like just a red, scaly patch and its appearance is variable, it's easy to confuse it with other skin conditions. Your notes list quite a few potential lookalikes. These are the differential diagnoses that need ruling out.
Given how varied it can look, I imagine that differential list must be pretty broad. It is, yeah. You've got things like actinic keratosis, which is another type of precancerous lesion caused by sun damage, so that's definitely on the list. Also, common inflammatory conditions like psoriasis or seborrheic dermatitis or different types of eczema like discoid eczema.
So inflammatory stuff mainly. Or are there other cancers or lymphomas on that list too?
Yes, definitely. You need to differentiate it from things like cutaneous T-cell lymphoma, which is a skin lymphoma, also lichen planus, superficial basal cell carcinoma, that's another common type of skin cancer, but different from squamous cell. And as we touched on, especially if it's pigmented, you absolutely have to consider malignant melanoma.
Wow, okay, that's a really wide range of possibilities then, from simple inflammation right through to quite serious cancers. How on earth do you definitively figure out that it is Bowen's disease and not one of those many, many other things?
Right, and this brings us neatly to investigations. And here, the message from the notes is crystal clear. The essential diagnostic step, the absolute gold standard, is a skin biopsy for histopathological examination.
So you have to take a sample.
You have to take a sample and look at the tissue under a microscope. There's no way around it for definitive diagnosis.
And why is that biopsy so absolutely crucial? Is it just for the label?
Well, it's partly for the label, to confirm it is Bowen's disease, but primarily, and absolutely critically, it's needed to exclude invasive squamous cell carcinoma. Remember that low, but not zero, risk of progression we discussed. The biopsy confirms it hasn't progressed yet, that it's still safely in situ.
Okay. What kind of biopsy is usually done? Do you take the whole thing out?
Often, yes, an excision biopsy is preferred. That means removing the entire lesion. This is great because it serves both diagnostic and often therapeutic purposes. You're getting rid of it at the same time.
Makes sense.
However, if the clinical picture isn't entirely classic, or maybe the lesion is very large or in a tricky spot and you just need confirmation first, then a punch biopsy can be enough. That just takes a small core of tissue for the histological analysis.
And when the pathologist looks at that biopsy sample under the microscope, what are the key features they're looking for that just scream Bowen's disease and also, crucially, confirm it's still in situ?
Okay, this is really high yield for understanding the condition pathologically. They look for what are called atypical keratinocytes. These are the abnormal squamous cells spread throughout the entire thickness of the epidermis, from bottom to top. This is called full thickness atypia.
So the whole layer is affected.
The whole epidermal layer shows these abnormal cells. They'll also see a loss of polarity, meaning the cells are disorganized, arranged chaotically, not in their usual neat, orderly layers.
Ah, like a messy pile of bricks instead of a nicely structured wall.
That's a great analogy, exactly like that. You might also see some weird-looking cells, maybe multinucleate keratinocyte cells with multiple nuclei. And then the absolutely non-negotiable feature, the thing that confirms it's still in situ, is that intact basement membrane we talked about. That boundary layer between the epidermis and dermis must be unbroken.
Got it. Intact basement membrane is key for in situ.
Absolutely fundamental. Now, while experienced clinicians can often make a strong presumptive diagnosis just by looking, maybe helped by a dermatoscope that's a special magnifying tool for skin,
Right.
the biopsy remains the definitive step whenever there's any doubt at all, and it's essential, really, for ruling out invasion.
So once you've got that definitive biopsy result, it's confirmed as Bowen's disease, thankfully still in situ. How do you treat it? What are the management options available, particularly here in the UK?
Okay, treatment. There are actually several effective options used, and the best choice really depends on various factors. Surgical excision is one common method, just cutting the lesion out completely.
Straightforward.
Yep. Another is curettage, which involves scraping the lesion away, often followed by cautery, which uses heat to burn the base and stop any bleeding. Cryotherapy is also very common, freezing the lesion off with liquid nitrogen.
Are there non-surgical options too? Maybe creams or something less invasive?
Yes, absolutely. Topical therapies are widely used and are often considered first line, actually, especially for maybe larger lesions where surgery might be difficult or could leave a significant scar. Good examples are creams like imiquimod,
I've heard of that one.
yes, and 5-fluorouracil, often called 5-FU. These work in different ways. either stimulating the local immune system to attack the abnormal cells or directly killing the rapidly dividing cells.
Okay. What about treatments for perhaps larger areas or if someone has multiple patches?
Yeah, for those situations, photodynamic therapy, or PDT, is very valuable. This involves applying a special light-sensitive cream to the area, letting it soak in, and then exposing the area to a specific wavelength of light. This activates the cream and selectively destroys the abnormal Bowen cells.
Does that work well?
It's particularly useful for larger or multiple lesions and often gives really good cosmetic results, which is important depending on the location. For very expensive or multiple lesions, or maybe if surgery just isn't a suitable option for the patient, radiotherapy can also be used. And finally, for really challenging cases, maybe in cosmetically sensitive areas like the face, or tricky locations or recurrent lesions, a specialized surgical technique called Mohs microsurgery might be employed. That offers very high cure rates by checking margins microscopically during the surgery.
Wow, quite a toolkit then.
Yes, so as you can see, there's no single best treatment that fits everyone. The decision really comes down to things like the size and location of the lesion, how many lesions there are, the patient's overall health, their preferences, cosmetic considerations, lots to weigh up.
And how successful are these treatments generally? Is recurrence, like the lesion coming back, much of a problem?
They are generally very effective, which is why the prognosis is so good. However, it's true that all treatment options do carry some risk of recurrence. The notes suggest typically around 5% to 10%.
Okay, so not zero.
Not zero, and factors like the patient's age, the specific characteristics of the lesion itself, and its location can influence that likelihood. So it's really important to have that discussion with the patient about the pros and cons of each option, including the potential for recurrence.
Right, managing expectations. Okay, so we've defined it, talked causes, what it looks like, how to diagnose it definitively with biopsy, and the range of treatments.
Yeah.
What's the overall outlook then for someone who's had Bowen's disease treated? The prognosis.
As we've touched on a few times, the prognosis is excellent, especially with appropriate treatment. Most people are effectively cured of that specific lesion.
That's great news. And just to reiterate, if it's not treated, what was that risk of it progressing to invasive SCC again?
If left untreated, the notes suggest about 3% of typical Bowen's cases might progress over time. And this is a really crucial detail to remember: lesions occurring in the genital area, that erythroplasia of Queyrat we mentioned, they seem to have a significantly higher risk of progression, possibly around 10%.
Okay, so location matters for risk?
Definitely. That highlights why identifying and treating those specific genital lesions promptly is so important. And importantly, spread to other parts of the body and metastases is explicitly stated as being rare in Bowen's disease itself. Because it's stuck in the epidermis, it just doesn't have easy access to the blood vessels or lymphatic channels it would need to spread elsewhere.
That's very reassuring. And is there any connection, according to the notes, between having Bowen's disease and maybe developing internal cancers later on?
No, the notes are quite clear on this. They state there is no known association between having Bowen's disease and developing internal malignancies. That's another really key point for patient reassurance.
Okay, good. So the problem is localized to the skin. It very rarely spreads from that initial site if treated, and it doesn't signal cancer elsewhere in the body.
Yeah.
But is there any kind of long-term risk after you've had Bowen's, even if that specific lesion is cured?
Yes, and this is a really, really high-yield point to take away. Having Bowen's disease acts as a significant marker. It tells you that that person is at an increased risk of developing other non-melanoma skin cancers, NMSCs, in the future.
So not necessarily the Bowen's coming back, but new, different skin cancers,
Right.
like basal cell or squamous cell carcinomas.
Exactly. It's not that the original Bowen's is guaranteed to cause problems again, but its presence signifies that the person's skin has sustained significant damage from the underlying risk factors, especially UV radiation over the years. This makes them fundamentally more susceptible to developing completely new skin cancers over time.
Okay. So it's less about that one lesion and more of a general warning sign about their skin's overall health and sun damage history.
Precisely. It tells you this person's skin is vulnerable. And because of this increased risk of future NMSCs, follow-up is important after treatment. It usually needs to be individualized based on the patient's specific risk factors, but often includes ongoing skin checks and monitoring for any new suspicious spots.
Makes sense.
So given that really strong link to UV damage and this risk of developing more skin cancers later on, prevention is clearly vital, isn't it? What steps can people actually take to reduce their risk of getting Bowen's disease or indeed other NMSCs in the first place?
What are the key preventative measures highlighted?
Well, it really boils down to sensible sun protection behaviors. So limiting your overall UV exposure, especially avoiding the sun during the peak hours of the day, sort of midday when the UV rays are strongest. Wearing protective clothing, hats, sunglasses.
Sunscreen, too, I assume. That's always mentioned.
Absolutely. Regular use and, importantly, reapplication of a broad-spectrum sunscreen, one that covers both UVA and UVB rays, is essential. And the notes explicitly mention avoiding sunbed use altogether, as they expose you to concentrated UV radiation. And there's that specific point, again, about organ transplant recipients. Because of their immunosuppression, they are particularly vulnerable and really need to be extra vigilant with all aspects of sun protection and regular sunscreen use.
Okay. And finally, just to round things off, let's quickly touch on what happens if Bowen's is not treated or maybe isn't treated effectively enough. What are the potential complications?
The primary complication, the main worry, as we've kind of circled back to a few times, is that progression to invasive squamous cell carcinoma if the lesion is left untreated or perhaps managed inadequately.
And if it does become invasive SCC, what are the implications then?
Well, invasive SCC carries a significantly higher risk of metastasis, meaning spreading, usually to nearby lymph nodes initially, but potentially to other parts of the body compared to the purely in situ Bowen's disease. And of course, it also involves potential complications from the local invasive growth itself, as it can start affecting surrounding tissues and organs depending on where it is and how deep it goes.
Right. Okay. Wow, that was a really comprehensive deep dive into Bowen's disease based entirely on your notes. We've really unpacked it, haven't we? From the core definition, what in situ actually means, through the causes like UV and HPV, the pathophysiology, how it actually develops, staying in that top layer, what it looks like, including all those variations and that specific genital form.
Erythroplasia of Querot, yeah.
How crucial that biopsy is for diagnosis. And, critically, excluding invasion, the whole range of treatment options, from creams to surgery to PDT, and then finishing with that generally excellent prognosis, but with important caveats.
Absolutely. And I think pulling out those really high-yield points helps solidify it, doesn't it? Things like the intact basement membrane being the absolute definition of in situ, the specific link with HPV-16, that interesting UK versus other country location difference for some reason.
Yeah, the lower legs thing.
The higher risk profile for genital lesions, understanding those key histological features like full thickness atypia simply, and perhaps most importantly from a long-term perspective, the fact that having had Bowen's flags you for a significantly higher risk of future skin cancers. It really helps connect the dots.
So what does this all really mean in practice for someone listening? Maybe the biggest takeaway is that while Bowen's disease itself is very treatable, often straightforwardly cured with an excellent outcome, its presence is a crucial signpost. It's a message from your skin about past damage, and it highlights a really significant ongoing risk for developing other skin cancers down the line, which just puts a massive emphasis on long-term sun protection and vigilance, regular skin checks. It's almost like a wake-up call from your skin, isn't it?
I think that's a perfect way to put it, a wake-up call.
Definitely something to keep in mind. Okay, that wraps up this deep dive. If you are revising for the MSRA or just want to brush up on your medical knowledge, remember you can find loads more resources over at passmsra.com.
And also at freemsra.com for extra questions and materials. Until next time, keep learning and keep digging deep.